Dr. Dodo, thank you for the information you shared. And Dr. Sista, thank you very much for giving a very balanced presentation about comparing medical therapy with anticoagulation versus thrombolytic therapy, and that there is really no data to support that one is superior to the other. As a surgeon who has been doing surgical pulmonary embolectomy for nearly 40 years, I pose to make a suggestion that in the trial that should be done, maybe it should be a 3-arm trial, anticoagulation therapy versus thrombolytic therapy versus surgical therapy. I know this is a big question to ask, and I seriously doubt it will happen because of the obvious reason that the technology in catheter-directed therapy is very promising, very exciting, and it has an extremely expansive role as we all are witnessing this revolutionary front in the management of pulmonary embolism. That said, I'm going to summarize to you what you can do surgically for the treatment of patients who fail or who do not respond or for whatever reason do not do well with the medical therapy or the percutaneous therapy. Basically, you will have to find a surgeon who can do it, and he or she has 2 approaches. One is to make a sternotomy and put them on bypass, open the pulmonary artery and clean it up. Or 2, pursue a less invasive technique, which I and others have developed to put the patient on fem-fem bypass and make a 1.5-inch incision in the left third intercostal space, open the pulmonary artery, and surgically clean up the artery. My personal data over years show that those patients who undergo surgical treatment have a survival as good or better than the catheter-directed. My data over 10-year follow-up, we've had 87% survival of patients, and those who died did not die from a cardiac problem or pulmonary problem, but died secondary to other issues such as cancer. So my practice in the surgical support of interventionists who are dealing with pulmonary embolism has shifted. Instead of being a primary surgical participant in doing the surgical procedures that I do, now I am more involved in providing the support for interventionists who may get into trouble when they take care of such a patient. So really, the title of my talk is not the surgical treatment of pulmonary embolectomy, but it is what's in a name. And that words carry hidden baggage, and they can shape the material outcomes of what we do. To rephrase it, is pulmonary embolism the appropriate term for the disease process that we all are interested in? Or is it, or should it be, right ventricular acute outflow tract obstruction? And I'm going to raise a number of questions for you. I will try not to answer those questions, but leave them for you to reflect upon as you proceed with your career. Is it pulmonary embolism, or should it be acute right ventricular outflow obstruction? Is the attention being directed on the lungs more so than on the heart? In other words, is the name the wrong name? And are we looking at the lungs when we should look at the right ventricle? Is normalized oxygen in acute PE a reason for comfort? What is the cause of potential collapse in acute PE? Is it hypoxia or is it cardiac deterioration? And what are the signs of danger in acute PE? Is it RV ischemia, RV infarct, failed RV outflow, poor left ventricular filling, poor distal organ dysfunction, RV-triggered cardiac dysrhythmia? And what should be the desired solution, unloading the right ventricle or increasing oxygen saturation? At my stage in my career and at my age, I have become more of a philosopher than an actual just operator. I enjoy the philosophy of medicine now, and that's the topic of today, really. It's my philosophy of how to approach. And I'm going to share with you a case in point that will summarize those issues that I have pointed out. A 78-year-old person with asthma, COPD, the usual hypertension, hyperlipidemia, who had had a previous pulmonary embolism triggered by a motor vehicle accident, came back more recently with discitis in the cervical spine, was on antibiotics, was in recovery, and presented to the emergency room with shortness of breath, chest pain, hypoxia, and tachycardia. And he had the appropriate workup with a CT scan showing a saddle embolus. And he had the following vital signs. He was tachycardic, he was tachypnic, his blood pressure was okay, he was desaturating relatively, his troponin was elevated, and his lactate was elevated. And of those, the things that bother me the most is probably the lactate of 5. Because once the lactate is above 2, then you're looking at someone who has 25% mortality if nothing is done to reverse that. So this is the patient, and here is the CT scan that you see. And I want you to take a look at that CT angiogram and decide for yourself whether this is an acute or maybe acute and chronic pulmonary embolus, because I think in our excitement of catheter-directed management, we may be not looking close enough for those who have probably a combination of acute and chronic pulmonary emboli. And here is the echo on this patient, and you see that the right ventricular function is not very good. The RV is dilated while the left ventricle is practically empty. This patient went to the IR suite by my very excellent intervention radiologist who performed a pulmonary angiogram, and promptly that patient arrested 3 times, and rightfully my colleague called for help because the patient was arrested first time, was resuscitated second time, resuscitated third time. And rightfully, my colleague gave the patient 50 milligram of TPA directly into the right atrium. At that point, we proceeded to place this patient on femoral arteriovenous bypass to support his hemodynamics. And if you look at the numbers here, you look at the patient's oxygen level, before the instrumentation, and throughout the process, his oxygenation was quite excellent. Despite his very high oxygenation, that patient arrested 3 times, requiring resuscitation. And a decision had to be made of proceeding or stopping. My colleagues, who was very experienced, decided to stop and made the right decision of giving thrombolytic therapy to that patient. And I think he saved his life, and together we put that patient on ECMO. And you see the patient here has a transfemoral arterial and venous, and positioned that venous in the right atrium and put him on an extracorporeal membrane oxygenator. Interestingly enough, on the left side, you see the X-ray before the procedure. On the right side, you see the X-ray 2 days later, and you see a hematoma that has developed in the upper mediastinum. On an examination, that patient was tender in the neck and in the upper mediastinum, indicating what we really knew, and that patient required over the next 4 days a total of 14 red blood cell transfusion. The patient, after 5 days on ECMO, made a very excellent recovery and had, after an initial stormy outcome, had stabilized and made an excellent recovery and went on to go home in excellent condition. So that brings me back to where I started. What is in a name? Are we really dealing with a pulmonary embolus? Is the lung the target organ of injury, or is it the right heart? And I beg to say that the lung happens to be there, but the one that is injured, it's the heart. And if anything, pulmonary embolism is probably a misnomer. It should be acute right ventricular outflow tract obstruction. That's the problem that we're dealing with, and that's the problem that we should reverse. This has a lot of impact. It's a politically very charged point because pulmonary embolism is in the hands of pulmonologists. And I dare say it should not be in the hands of pulmonologists, because pulmonologists are not qualified to deal with acute right ventricular dysfunction. It should be in the hands of interventional cardiologists and the management of that, at least those who have moderate severe or severe pulmonary embolism. That should be a cardiac problem to be managed by interventional cardiologists and cardiac surgeons, and those who are focused in acute hemodynamic dysfunction management. Thank you very much.